In December of 1945, the U.S. President Harry Truman designated the Marshall Islands as the Pacific Proving Ground for the U.S. nuclear testing program. The following February, the people of Bikini Atoll were asked by the U.S. government representatives to allow nuclear testing for the good of all mankind on their atoll. In March of 1946, the people of Bikini were transported by the U.S. Navy to Rongerik Atoll, 120 miles to the east, an atoll with too few resources to support their population. In July of 1946, the U.S. government commenced Operation Crossroads, the testing of 2 nuclear devices at Bikini Atoll.
The B-29 Dave's Dream takes off from Kwajalein to deliver a bomb equal to 50,000 tons of TNT. Cover your eye. Now, on the way. Radioactive cloud rises over 7 miles. The second test, Test Baker. King Judah of Bikini watches with Admiral Blandy as LST-60 moves into place.
15.
Cameras are ready aboard ship and in the sky.
2, 1, fire.
Then, in December of 1947, the U.S. government chose Eniwetok Atoll to be a second test site. The Eniwetokese were transported to Kwajalein Atoll to the southwest. In April of 1948, the U.S. government began Operation Sandstone at Eniwetok Atoll. Operation Sandstone consisted of a series of successively larger atomic weapons tests, with much higher yields than those of the Crossroads test before. In March of 1954, the U.S. government commenced Operation Castle at Bikini Atoll.
7, 6, 5, 4, 3, 2, 1, go!
The Castle Bravo shot was detonated at 6:45 on the morning of March 1st, 1954. Within 6 minutes, the mushroom cloud peaked at 130,000 feet with a diameter of 100 kilometers. The Bravo shot would become the largest nuclear device ever tested by the United States and would have devastating consequences. A failure to postpone the test in light of the changing weather and wind patterns and the unexpectedly high yield of the Bravo shot resulted in the direct exposure of Marshall Islanders located on Rongelap, Alenganai, and Utrik atolls as a fallout cloud drifted east of target. Islands as far as 300 miles to the east of Bikini received high doses of radiation. "11 days after the Bravo shot, the Marshallese became the official test subjects of the Joint Task Force Research on Human Radiation Effects. Radiation levels prohibited resettlement, and the affected population remained scattered around the Marshall Islands. In 1986, the U.S. and Marshall Islands government entered into an agreement called the Compact of Free Association. In addition to the DOE research and health program that provides care for radiation-related illnesses of those directly exposed, the Compact provided funding for the 177 healthcare program to provide an integrated, comprehensive health care program including primary, secondary, and tertiary care. The Republic of the Marshall Islands consists of 29 major atolls made up of many islets, and 5 islands located in the North Pacific Ocean. Total land area is approximately 179 square kilometers, spread over 2 million square kilometers of ocean. 20% of this remains uninhabitable due to radiation contamination. The northern atolls are extremely isolated, and transportation to and from the islands is limited. Atolls such as Utrik only receive supplies from small boats every 3 to 6 months. The islands receive very little rain throughout the year, and the people are dependent upon rainwater catchments. Communications in the outer islands is limited to radio. Islanders on Majuro must make the hour-long trek across coral reef and through waist-deep water in order to reach the landing strip. Small boats can only be used for this trip during high tide. Electricity is by generator power only and is routinely unavailable due to fuel shortages.
They are a group of people that were unfortunately affected by the nuclear testing. We should treat them, give them whatever they need.
Welcome to 177. This is our clinic here in Majuro, which happens to be the logistics center for the 4 atolls we take care. This is our receiving room wherein the patients would wait, and usually we number about 15 to 25 patients a day. Right here you'll see that these are the records of all the patients that
The Majuro Clinic sees about 6,000 patients yearly. In addition to the Majuro Clinic, dispensaries are located on Utrik and Utrik Atolls, Kili Island, and Majuro Island. These dispensaries serve approximately 3,000 people, and until recently were attended by health assistants and visits by health teams for only 1 week per quarter. The 177 provides care for the populations of the 4 exposed atolls. When the program was approved, there was an estimated membership of only 3,000, including the originally exposed population, their descendants, and those Marshallese diagnosed as having one of the 25 radiation-related illnesses. In order to improve patient services and the continuity of care, the primary healthcare initiative was established in which full-time physicians were placed on the outer islands.
I see a big difference between when we had the health assistants on their own in the outer islands, and now that we started the primary healthcare initiative. We were able to send these doctors to help the health assistant in public health, and especially to bring up the strengthen the primary healthcare preventive services in the islands.
Physicians were recruited by Trinity Health International from Nepal and the Philippines. These physicians are well trained and able to work with limited support and in minimal facilities on these remote outer islands. Coming from developing countries, they are practiced in the treatment of many diseases no longer found in the West, but are still present in the Marshall Islands. The physicians readily adapt to the language and have been able to improve physician-patient relations, compliance, and recovery rates. Physicians work with public health to implement preventive health and treatment programs. They work to improve community awareness and involvement in healthcare issues. And they work closely with health assistants to improve clinical skills and sustainability.
So one success story that I can share with you is that I had one delivery of a premature baby, like 31 weeks. We weren't able to refer them to Majuro because it's almost time for her to deliver. The baby weighed 2 pounds. And it's good, we had oxygen, we had suction machine, and we were able to put an IV on the baby, and now the baby's quite big, and I think that one is one of the more successful things that I did in this island.
Diseases like TB and leprosy are still quite common in the Marshalls. In January of 2003, with the help of public health survey data, a TB eradication program was initiated by a team consisting of 177 staff, CDC and RMI public health personnel. At-risk members of the population were screened, examined, and tested before undergoing treatment at the Majuro or at the dispensaries.
(177) healthcare program has given very effective preventive curative treatment to our patient. People in 4 atolls will enjoy the effective preventive and curative treatment from the 177 healthcare program.
The Marshall Islands has one of the highest rates of diabetes around the globe. The shift from traditional diets to those of imported foods high in sugar and fat has led to adult obesity and a rise in non-communicable diseases. Diabetes-related illnesses such as cataracts affect a significant portion of the population, and sepsis is among the leading causes of death.
Because I sleep in a nearby room, so it's easy for the people to come to the clinic and then approach me. They can knock, and especially because I speak their language, so they don't have that fear that I'm a doctor. They just treat me as a friend, as their friend, and as a local people from Majuro. So it's easy. They just come and knock my room, and then I'm just here in the clinic within few minutes. There are some cases that we really need to take care of them, because people, they don't have the knowledge about medicine and they don't understand. So there are superstitious belief about using some kind of medicine, like medicine for diabetes and medicine for asthma, inhaler kind of medicine. But through slow practice and through health education, I think we are improving that. Kalanginan ko kanan ke pa koin ewi wawen Commandment Hospital, Cirebana Hospital.
Hai kwani yemo inge au jiterne ini ne kani yemo kuyo igite Cirebala kana ambu lulur yagi igite na adu pancebina tadaran ni jenri itu alam lulur yagi tunang mi roam ka promeri itu nyangin metungan au jiterne nam koy berenot ada kibangirim kau berenot arbijin mejato.
Specialty medical missions are still a necessary component of care. In August of 2002 and again in 2005, the 177 undertook an eye and ENT mission with the help of specialists from Nepal. Doctors traveled with surgery equipment. The dispensaries were sterilized and acted as makeshift surgical rooms. Approximately 5 surgeries were performed on every island during each mission, and due to the skill of the visiting physicians, all surgeries were successful. Prior to 2005, funding for the 177 healthcare program came from the Nuclear Claims Trust Fund as part of the Compact of Free Association and had a fixed budget of $2 million per year. The agreed-upon funding of the Compact of Free Association has lapsed. However, the necessity of the 177 healthcare program to continue to provide care has not. The RMI requested that the U.S. government grant adequate funding to the 177 healthcare program to meet the current level of need during 2003 negotiations for the Changed Circumstance Agreement. The U.S. Congress rejected any additional funding to the RMI government beyond the original allocated amount, and long-term provisions for U.S. funding have not yet been made. The 177 HCP is temporarily supported by a $1 million a year U.S. federal grant.
We have records showing that whole Marshall Islands is affected by by radiation, and we should continue to seek and make U.S. provide accordingly, or provide the good. It is their obligation to provide medical funding. For medical to all the people that are affected by radiation.
I think a lot of my issues and concern are conditioned based upon any additional funding that we will receive in the future for a larger amount. We're living within a $1 million budget. We've been used to $2 million, but hopefully. The U.S. government would, respond positively to our request for a larger amount to, deliver more, quality services. And we've discussed, a lot of ways where we can improve the delivery of these kinds of services to our constituents. We've talked about, how do we address logistics and be responsive to emergency call. In the past, there have been people dying, because the logistics were not in order, and the protocols, were not well established. That in time when we have to send helicopters or airplanes, sometime because due to shortages of funding, etc. We face these kind of challenges, but with appropriate, future funding, I think we could have a readiness program to those kind of situations.
It's the limitation that we always have from the beginning. It's not. It's due to the budget. And oftentimes it takes us from concentrating on what is needed to be done because of the limitation of financial assistance.
And to me, it really doesn't matter who's treating who. But as long as we are providing a very well thought out primary health care program to either 177 or Marshall Islands as a whole, we should work together. It's like 177 is another department of the Ministry of Health. To me, I look at that way.
Life on these remote atolls is not always easy. With limited infrastructure and government funds, the future of the 177 healthcare program has not yet been determined.